Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I will be discussing two more challenging lupus cases with Professors David Isenberg and Thomas Dörner from the Lupus Academy Steering Committee. David and Thomas, welcome, and thank you so much for joining us today. So let's start to discuss the cases. The first one, David, is a case from your clinic that you sent us for discussion. Let's look at some background of this young woman. This young woman was 14 years old when she presented with menorrhagia and epistaxis. She had a pretty severe 4.9 grams per deciliter of anemia, microcytic 1, and she had severe thrombocytopenia, less than 25. She was diagnosed with acute idiopathic thrombocytopenic purpura, and she was treated with steroids, prednisolone. After 9 months, without improving the platelets count, she underwent a splenectomy, after which her platelets returned to normal. So, David, what is the significance of the patient's platelets returning to normal after a splenectomy? Do you have comments on it?
So, as you gather from history, this was in the old days, pre-rituximab. But for patients like her who did not respond to steroids, the choices were very, very limited. And one of the choices, in fact, the main choice, was indeed to do a splenectomy. And it was estimated, I did a review of patients that we had with lupus and APS, actually, some years ago. And I would estimate that between 4 and 5 out of 6 patients responded to splenectomy. And in fact, I wrote up 4 patients with APS, all of whom responded in terms of the platelet count returning to normal. When you remove the spleen, of course, you also took out an organ which is of great interest. And my now retired delightful colleague, Peter Madison, was very, very delighted when I sent him half of this patient's spleen. And he wrote back and said, "This is 3,000 years worth of experiments you've given me." So that, of course, no longer applies now that we have rituximab. So although splenectomy was a major operation and patients really were mandated to remain on penicillin afterwards, it could be very successful in terms of treating the low platelet count.
Thank you. Thomas, this patient started with immune thrombocytopenia, and we are already guessing that she's going to have lupus. So how might the initial ITP presentation be a precursor of having lupus on the future? What is your idea of how many patients would go for SLE in the future?
So to the best of my knowledge, there's no good or reliable literature. And I think in my experiences, there is a possibility that some of the initially ITP patients subsequently develop a more larger organ manifestation, which you can then categorize as lupus. I don't know what David thinks about this, but lucky moment that the splenectomy works, and usually only in about 60–70% it works. My question is, and it would already fulfill maybe a little bit more the criteria of lupus, was there also an autoimmune hemolytic anemia, because there was a substantial anemia at the beginning? And what happened with the anemia? Did this respond to the initial treatment of the DMARDs?
So to answer the first bit first, Thomas is right. The literature is pretty disappointing. There is a paper by an American guy called Karpatkin, 25 years old, something like that, which indicated that about 15% of patients with so-called ITP went on to get lupus. And you might have thought that those were the patients most likely to have a positive ANA, since we know from the famous studies in the US Army 20-odd years ago that the anti-nuclear antibodies of various sorts could be present for years before the clinical features, but Karpatkin did not report that actually. So it's I think the question is still rather up in the air, but I think there is certainly a small number of patients with ITP will go on subsequent to get lupus. As far as the anemia is concerned, that was thought to be significantly a microcytic problem and probably due to very heavy periods rather than an autoimmune process in her particular case. And from memory, this is a long time ago, that was largely corrected with iron oral, and I think she might well have some intravenous iron as well. So that wasn't a part of the so-called Evans syndrome that sometimes gets.
Yeah, exactly. Yeah, Evans syndrome was the key word. Yeah, exactly. Thank you.
So let's go on with the rest of the follow-up. When she was 24, 10 years later, following a trip to Bombay, she developed fever, almost 40 degrees Celsius, sweats, weight loss, and arthralgia. She was admitted to hospital, but there was no evidence of any tropical disease. They were not found. And she persisted with fever, polyarthritis, alopecia, and then there were lab results with a positive ANA, anti-Rho, anti-La, along with the lupus anticoagulant phenomena, positive, and this led to the diagnosis of lupus. So, David, here there are clinical and serological key features that led to the diagnosis of lupus, and they do not happen with ITP with SLE. Can you please comment on this?
Well, I will try to do my best, but I should just say that, and I don't know if this exists in either Portugal or in Germany, but in England, there are two specific tropical disease hospitals. One is in Liverpool and one is in London. And I get asked to go and see patients there about 2 or 3 times a year. And it's kind of funny in the sense that when you go to see these patients, certainly in the old days, the old notes would be about that thick, full of negative tropical tests. There are so many tropical tests that they do. So when patients present with fever and they've just been in places like India or Africa or wherever, they come back to London, they've got a fever, they get sent to this hospital, a million tests get done. And then when everything comes back negative, somebody somewhere says, you know what, let's do an ANA. Oh my God, it's positive. We just got Professor Isenberg. He will sort this out for us. And I've only ever made 2 diagnoses in this situation. One is lupus, which is easy, and the other is adult onset stills, which I've made several diagnoses in the hospital tropical medicine, actually. So this was a patient who clearly had gone on to develop more other aspects of lupus. Her disease had clearly progressed, and she had some other features which we'll come on to in a moment. But this, I guess, is the sort of case that Karpatkin was referring to, that some patients don't stay with ITP but develop other antibodies and other clinical features.
Okay, there's a particular picture on the antibodies that I would like just to hear your comment. Most of the literature presents that hematological features in lupus are mostly of them in positive anti-Rho or anti-La patients. What is your experience with this feature?
I must say my experience has been very, very diverse, and I've seen it as often as I've not seen it. It's not been a feature that sort of really stood out for me. I don't know if Thomas may have a different experience, but I haven't noticed that particularly in my practice.
Thomas, too.
I would agree. I could not give you a good, consistent picture on this. Anti-Rho and La usually has a very mild course of the disease. If anti-Rho is alone, for whatever reason, it's a more severe form or course of the disease. That's something what we learned 20, 30 years ago already, and that's quite consistent, I think.
Okay, thank you. So this patient had received no vaccination at the time of splenectomy, and the registrar that was taking care of the patient gave her the Haemophilus influenza vaccination. 4 days later, she developed numbness and burning pain in the feet, and the electromyogram findings were consistent with Guillain-Barré syndrome. The CSF analysis showed not an increased protein level, and she maintained fever, her blood counts were low, and she had normal anti-DNA antibody level at this time. Thomas, can you please comment on the evolution at this point? And what do you think about vaccination during a flare? Does it matter?
I think before I comment on this, I would say it would have been better to vaccinate the patient immediately after the splenectomy, how it is recommended, to have broader coverage. There's a lot of literature, and that is a little bit contradictory about the risk of OPSI syndrome. There's more old literature, but recently it has, to the best of my knowledge, not so strictly re-evaluated whether this is true or not. The issue in this patient is that in an apparently active flare, vaccination happened. And this, on the one hand, the immune system is somehow occupied with the activation by the disease and cannot really properly elicit a vaccine response. And the issue in particular here is the question whether there is a potential side effect of inducing Guillain-Barré syndrome, which is very often one of the, let's say, severe adverse events that can happen with one or the other vaccination. I cannot give you a conclusive answer here. When I was thinking about this, usually if you have an active infection, the best is maybe in this situation, it would have been better to give IVIG to have some immediate coverage, and subsequently, when there is a kind of decline of the disease activity, then actively vaccinate. But I will not discuss this in detail because I think it's a clinical decision when to do what particular thing.
Thank you. And actually, on the next 24 hours after this follow-up evaluation, she had 4 grand mal seizures, so generalized tonic-clonic seizures. And she did a brain MRI, and it was compatible with widespread vasculitic lesions. So, David, what do you think about the evolution right now? How can you figure out what's going on? Do you still think that Guillain-Barré was Guillain-Barré?
So this, of course, is the issue. And I remember the case very well because we had a very good registrar at the time who had gone off to the library, as one did in those days. Thomas will remember that. You may not remember the medical libraries.
I remember current contents in order to get the newest publication.
Exactly. So the issue was this. She found a case report of a patient who'd had a splenectomy, who'd had a vaccination, and who had then clearly Guillain-Barré. And she reported this to me, and this was news to me at that time, and this was very interesting. However, it wasn't quite so straightforward. On the EMG, they'd found a thing called an F wave, which my EMG-ologist colleagues say, yes, that is found in Guillain-Barré, but it's not absolutely specific for it. But she also had some sensory symptoms. So whereas Guillain-Barré is motor, of course. So it was always a slightly open question, was this, strictly speaking, a post-vaccination complication, or was this actually CNS manifestations, or this CNS lupus developing? And the 4 seizures, which actually happened to occur during the lupus clinic, I remember leaving the clinic to go and see her. So I think once we got the 4, or she'd had the 4 seizures, it became pretty clear this was probably nothing much to do with the vaccine. This was CNS lupus developing in a patient who'd started off with ITP and then developed some other lupus features and now had CNS lupus. So that was the way that it evolved. But certainly for 24 hours, we were very, very puzzled as to what on earth was going on.
And she was treated, so after these 4 seizures, she was treated with idle steroids, cyclophosphamide, and carbamazepine as an anticonvulsivant. These results, she had a clinical improvement. So, Thomas, this happened several years ago. If now, what would be your choices, both for induction and maintenance therapy with this pretty severe systemic lupus with CNS involvement, vasculitis being seen on the MRI? And I always have a question it is, when we say high-dose steroids, what are we talking about? So what is high-dose steroids? How many steroids would you use and how?
I personally have an arbitrary architecture of high-dose steroids. It starts with 500 milligram methylprednisolone. Everything below is intermediate dose. So
okay.
Maybe 250, 500, that's about the threshold, but I would use 1,000 milligram, maybe over 3 days and taper it down. In the case, the young lady, and I think most likely David would agree with me, I would rather replace the cyclophosphamide by rituximab in this situation. I still think carbamazepine is still a kind of reference drug. I think even our neurologists, when we consult them, they would recommend this right now. Maybe some of the newer derivatives or versions of carbamazepine. But on the other hand, I still wanted to make the point at the time when I'm not quite sure about the diagnosis. Sometimes it's good to get a little bit, gain time to give 2 days IVIG at 800 milligrams per kg. So in order to gain time, prevent a little bit an explosion of a potential infection, and maybe also using the immunomodulatory effects of IVIG. But everything else, great at that time, David.
Well, I feel now I have to make a public confession. I'm going to do it here and in front of you, and I'm also going to tell you a strange story from history. So we all do things in life which we regret, and one thing which I most regret professionally is I was 10, 15 years ago, I was talked into writing an article called Intravenous Cyclophosphamide, Goodbye to All That. And I deeply regret ever having written it, because I do think in certain circumstances, cyclophosphamide remains a very useful drug. Yeah. And CNS lupus, I think, actually is one of those situations. And sometimes in nephritis patients who can't take mycophenolate, it's also can be very helpful. So I admit to failure. I should not have written that paper. Mea culpa, what I'd like to say. Secondly, many, many years ago, my colleague Joe Edwards, who, as Thomas will know very well, was the first person to use rituximab for the treatment of rheumatoid arthritis. He and I did a very curious study, which when I look back at it, I'm kind of proud of it, actually. It was a comparison between patients given 3 100 milligram infusions of methylprednisolone against 3 1,000 milligram doses. And we tried to sort of personalize the outcome with these patients. And we published it literally 40 years ago. Obviously, I was still at school. It was a very long time ago. But actually, the truth was we couldn't see a big difference between the ones given the 1,000 milligram doses times 3 or the ones given 100 milligrams. So I'm a great believer, and I suspect you two are also, the best dose of steroids is the lowest possible dose for the shortest possible period of time, and I haven't really changed that. So in this case, I would probably have given 500 milligrams times 3. As regards to anticonvulsants, my colleagues in neurology are now completely obsessed with levetiracetam, which seems to be the anticonvulsant of choice. I suspect if she presented today, she would have been started on that by my colleagues. This is a little bit out with my personal experience, but that seems to be their kind of go-to anticonvulsant at the moment.
Can I ask you one question, David?
Sure.
Plasmapheresis, would have this been one option?
So now you're taking me back. My lupus career got started with plasma exchange. I was brought in on a project to look at the use of plasma exchange in lupus, and I was right at the end of it, actually. I found plasma exchange to be very helpful in the treatment of some very difficult to treat APS patients. I have never used a great deal of it, and actually this is to do with a study from North Germany, which got published again years and years ago. They did a comparison of cyclophosphamide plus plasma exchange versus a dummy for the plasma exchange with the cyclophosphamide, and it seemed that it was the cyclophosphamide that was the main really good thing. There was a big study, actually, 30 centers, 150 patients or something. So I've actually followed the learnings from that study, and I've tended to go. I haven't used a lot of plasma exchange in lupus over the years.
So now I do have a question for both of you that has something to do with the case, but not only. 3 weeks ago, we had in our hospital a pretty severe lupus patient with MRI showing vasculitis, and she was really bad. What did we decide to do? We decided to do rituximab with cyclophosphamide. So, because we remembered your first protocol, David, and okay, she's so bad. We are really afraid that rituximab doesn't kick just now. We're going to use cyclophosphamide. Can you please go just giving a little bit of a reasoning here to when would you choose again rituximab with cyclophosphamide?
Okay.
And
So
what does it mean
okay.
physiopathologically?
So the reason that Joe Edwards and Joe Cambridge introduced the idea of rituximab with cyclophosphamide and a bit of steroid was because those 25 years ago, those were the three drugs which we had available which could reduce B cells. They were after reduction of B cells. So those were the three drugs available. So they came up with this little composite of those three. And the year later, when I started using it to treat lupus patients, I thought, well, this seems to be something of a winning team. Why change it? So we started off for the first 4 or 5 years doing exactly that. 2 shots of rituximab, 2 weeks apart, and then one day after Ritux, they got some cyclophosphamide, I think mostly about 500 or 750 minutes. 750 was the preferred dose, and a little bit of steroid just to reduce any reactions to the rituximab, and it seemed to work. What we found was that several patients came back to us and said, look, rituximab was not a problem, but didn't like the cyclophosphamide very much, maybe rather sick, didn't really want to take that again. And then we discovered that when we repeated those doses 6 months later or a year later, actually, for many of the patients, 2 shots of Ritux was fine. But as your question rather implies, for the more severely active patients, we actually still do that older combination of Ritux plus cyclophosphamide. We still do that.
Thomas, do you have a comment on this?
Oh, yeah. I think the initial concept, it's a little bit unfortunate that it has been given up too early for me, retrospectively, because initially, the idea was also by Joe Edwards to eradicate the clones producing rheumatoid factor, not being aware that this is only indirectly to some extent tackled. If you combine rituximab and cyclophosphamide, you deplete all of the B cells or the relevant memory B cells, etc. And with cyclophosphamide, you have an outreach into the bone marrow plasma cell pool. And I think this combination, one would love to see this combination against the CD19 CAR T if you immediately discontinue immunosuppression after the intervention. That would be the, and therefore I still think there is value and there is a rationale to combine cyclophosphamide and rituximab, as you nicely explained on clinical grounds.
Thank you so much. So she did the treatment. None of us disagree that it would be applied today also, and probably with rituximab. And 3 months later, the patient was doing well, and she developed hypertension with normal renal function. She was given enalapril, and the hypertension resolved rapidly, and the prednisolone was decreased to 15 milligrams a day. Azathioprine was on 50 milligrams a day. And she had a severe vasculitis skin rash that developed all of her body, including the scalp. Prednisolone was increased, methotrexate was added, and it led to a gradual resolution, but with residual hyperpigmentation. David, what were the characteristics of this vasculitis rash, and what do you think about it in this clinical picture of this patient, in this case?
So the challenge here was this patient was on several drugs. She had lupus, and we were rather unclear as to whether and in fact, even our dermatologists were rather unclear as to whether this was a drug-induced case or whether this was vasculitis linked to her lupus. Certainly, it was pretty widespread, and we were rather stuck. And it was interesting because this patient's father was a very aggressive guy. And he came to see me one day, very, very aggressive, and he said, I demand a second opinion. I must have a second opinion. And fortunately for me, the next day we were having a group meeting of the then BILAC group. It's in its infancy, but there weren't that many members. There were about 8 people were coming to the meeting. I said, you want 1 second opinion? I'm going to do better. I'm going to give you 8 second opinions. So I took Paul Baker and Mike Snaith and Peter Madison to see this patient, and they all agreed, it's very difficult. It could be drug-induced. It could. Everybody agreed, which we'd already decided we were going to do a biopsy, and the biopsy showed elements of both a drug-induced changes and also elements of a more idiopathic disease. So we concluded it could have been both. The dermatologist thought the enalapril was responsible, and apparently enalapril rashes, I didn't know this, can occur after the patient's been on the drug 2 or 3 months, which was the catch. And in fact, we stopped the enalapril, and in fact, that together with upping the steroids did make a difference. But I will never forget being having this demand, I must have 1 second opinion, and being able to respond, we'll give you 8 second opinions. That was a very good way to answer.
Thank you. So, and during the year after, the rash was not too speed to resolve, but as you said, the stopping enalapril was good. But she remained with some hyperpigmented patches.
She was Southeast Asian origin from India, so
yes,
that is a concern in that population. We do see hyperpigmentation in those patients sometimes.
And then she was on remission, and the anticonvulsivants was stopped, and the steroids, and she was training as a primary teacher. And 7 years after that, she again experienced recurrent fever, nausea, abdominal pain, and diarrhea over a 3-month period. She was admitted to hospital, and she had diffuse abdominal tenderness, and all the antibodies that were positive before were now normal or negative, and she had an X-ray, echography, blood cultures that were unremarkable, but the abdominal ultrasound showed that she has cholecystitis. And she was started on IV cefuroxime, and 2 days after treatment, she had another tonico-clonic generalized seizure with mild left hemiparesis and brisk left upper limbs jerks. She did again cerebral fluid analysis that showed slightly increased proteins, normal glucose, and minimal lymphocytes. And the MRI was suggestive of herpes encephalitis, but the PCR for herpes simplex was negative on the CSF. There were no oligoclonal bands. And then the inflammatory markers were really, really increased. CRP, 122 milligrams per liter, ESR, more than 120. And she was rapidly deteriorating, even with acyclovir, endovenous acyclovir. The fever persisted. The left hemiparesis was worsening, and she became unconscious without having seizure activity for that. And she repeated the MRI, which showed lesion progression with right temporal lobe involvement. So a biopsy was made, and the cerebral biopsy revealed chronic inflammatory infiltrates around small vessels and white metacapillaries, confirming small vessel vasculitis. You started her with IV methylprednisolone and monthly cyclophosphamide for 3 months, and then she had a full recovery with oral steroids and azathioprine in maintenance therapy. David, this is really challenging, and it is really extreme when you need to do a brain biopsy. So why do you think that a brain biopsy was necessary? Did it give you a definitive diagnosis in this case? And why again did you choose cyclophosphamide in this case with steroids?
Okay, so to go back a little bit in the story, the first notable thing was that when she represented some years later, 7 years later, she'd been very well, off all treatment for at least 5 years, doing just great. I'd seen her every 6 months and she was doing fine, and then she came back in with this abdominal tenderness, and then the scan suggested that she might have cholecystitis. And it's interesting to reflect, and we've actually looked at this, to ask the question, what percentage of lupus patients lose? We looked for the anti-nuclear antibody, but the same is true of antibodies to Rho and LAM, these other things. And we managed to find, and we published this about 10 years ago now, 100 lupus patients who we had followed up for a minimum of 10 years, who'd been strongly ANA positive when they first presented. They were tested by the same technician, same technique, even the same bit of equipment. And 10 years later, 17% of them have become ANA negative. So about one patient in 5, 1 in 6 lupus patients, and I should say clinically, they virtually had all gone back to good health as well. So you do see the loss of autoantibodies and some lupus patients occurring spontaneously in about 1 in 5, 1 in 6 patients if you follow them up for long enough periods of time. So what was baffling about this patient was what on earth was going on. We, as you implied, we wondered whether this could be a herpes simplex encephalitis. That we thought that was quite likely, but we found no evidence to support that. The scans, I'm sorry we can't show them to you, but are actually quite remarkable. The appearances are very hard to pin down. In fact, we had long discussions with the neurologists who said they just weren't quite sure what this was. Vasculitis was a possibility. A lymphoma was a distinct possibility, and that's what I suspected it was probably going to turn out to be. And I don't know what Thomas's experiences have been. In 30, 40 years, I've requested a brain biopsy in just 3 cases. And in each case, my colleagues and I have had a discussion before and to guess, frankly, what we thought the histology would show. And in every case, I've got it wrong. Each of those 3 cases, I thought this was going to be a non-Hodgkin's lymphoma or Hodgkin's lymphoma, and it was wrong. And what we found, as you said, was she had, in spite of having negative autoantibodies, including the ANCA incidentally, on the biopsy, she's got vasculitis. That's what she's got. Cerebral vasculitis. And for me, yeah, I would probably give her rituximab now, but the cyclophosphamide was available. So we do use it for cerebral vasculitis. So that seemed to be the one that we would best go for. That's what we went for with some steroids. And what was remarkable was that 2 days after we started the cyclophosphamide, she woke up. She'd been unconscious for some several days, and she woke up post-cyclophosphamide. It was almost miraculous, actually. So it clearly was the right drug for her, and it got her back, with the help of the steroids, back to good health.
This is really puzzling. Did the vasculitis was there since the first time? Did it just relapse because she had an infection, a pretty nasty infection? What was going on?
What triggered it? Perfectly good question. I don't have an answer. I would emphasize that she'd been well for at least 5 years before she got sick again. And I should emphasize also that her lupus autoantibodies had all gone, they'd all disappeared. So this was an isolated cerebral vasculitis, trigger unknown to me anyway.
Thomas, how do you interpret the case at this point? And there's something else that is puzzling. We know that in lupus patients, an elevated or increased CRP happens in so very rare situations, and this patient had really increased CRP. So how do you figure this? How do you interpret all this?
Yeah, I think that's really the characteristic of lupus, that despite lupus activity as high as possible, SLEDAI 30-something, usually it does not come along with CRP elevations. Yes. That has something to do with some apparently genetic defects of the IL-6 promoter in the liver, that the CRP is not turned on. So Journal of Clinical Investigation a couple of years ago, there was a very nice paper on this. I forgot the authors, but they delineated the underlying thing. That the clinical finding is remarkable from my side is that there is a kind of superimposed or hidden CNS vasculitis in this case.
Yeah.
What I would have done, since we have this possibility, maybe look also in addition to CRP for procalcitonin in order to rule out bacterial infection, parasitic infection, etc. On the other hand, the question is whether other NMDA serology and other, that's almost an explosion of neuroimmunological findings, autoantibodies that are categorizing sub-entities of CNS or encephalomyelitis, etc., that not, this is a kind of combined situation of such an neuroimmunological disorder, mainly affecting the CNS, but having some features also with lupus. That is a kind of overlap syndrome. Coming back to the CRP, the only overlap I'm aware that the CRP is getting elevated is lupus and RA. It's also sometimes called lupus. There it's a normal situation, but otherwise I think that's a really unique case here. Very unique.
I agree.
And it's triggering. Most of the times when there is cerebral vasculitis in the lupus, the CSF analysis is not so changed. And at the first time, it was normal, and now it had slight increased proteins, a little bit of lymphocytes, and we don't know what exactly this means on the lupus activity, on the vasculitis, and so it's a little bit strange. It's really a little bit strange.
But maybe what I can add is the advances in neuroimaging are really remarkable. They can identify in the meantime really characteristics of CNS sarcoidosis and certain bugs. They can really segregate this much better. And I think this is a good opportunity for artificial intelligence to improve there. That's really something where we can save a lot of headache. And on the other hand, coming back to David's question about the CNS biopsy, we very infrequently still do this with our patients. But what I can tell you, our neurosurgeons, they love this because it saves them some certain operations when they are not clear about the dignity. They do this almost on a daily basis with a lot of very good, in the appropriate precautions, very safe, I have to say.
So, returning to the case, although she got better back then from the second CNS flare, sadly, approximately 3 years after recovery, this patient died unexpectedly during a visit to India. And the postmortem was inconclusive. She had a family history of lupus with both a full and a half sister affected. And that would be another podcast episode for discussion. What do the genetic monogenic lupus would had on this discussion? So, David, do you have any further comments on this case?
Only just a little story, I suppose. So this patient has 3 sisters, and one of them, as you say, does have lupus, relatively mild lupus, and we still see her. What was very funny, and it was what happened to her was tragic. She went to India back to see some relatives, and she died in her sleep. As you say, the biopsy which was done in India was not conclusive, so we never really found out why she died, and she'd been well before then, so it was quite an awful thing. But about 2 years before she died, she came in to see me with a big smile on her face, and she said to me, "So," she said, "we now know where this lupus has come from." I said, "Excuse me?" She said, "Well, what happened was this." She said, a woman phoned me up that I did not know, and it turns out that she was the child of a relationship that my father had with my mother before they got married. And this woman is my half-sister. We got chatting, and then the half-sister, who I'd never met before, says to me, "Of course, you need to know that I have a disease that you will never have heard of." And so the patient says, "Well, tell us, what is that disease?" She says, "I have a disease called systemic lupus erythematosus." So the half sister had lupus, and one of the full sisters had lupus. So you feel genes have some part to play in this story.
Yes. So, Thomas, do you have any additional comment on this case?
I very much agree. There's a high likelihood of some inborn error of immunity, and that's maybe the case. And therefore, it is so. Whenever a lupus, maybe that's a kind of general point. Whenever a case is so abnormal, or seronegative rheumatoid arthritis, all the bells are ringing. There's something else, but does not fit really in our textbooks. And then maybe it's worthwhile to go for genetic analysis to find some of these known mutations. It will not take long, and we know all of the mutations.
Thank you so much. And let's move to the other case, which is also pretty rare, but completely different. So let's go with it. It's a case from your clinic, Thomas. So this is a woman that on a 33 years old, she's Caucasian, and she had a complex medical history. She was living with systemic lupus erythematosus for about 15 years. So she was diagnosed during her late teens, beginning of the 20s. She was on end-stage renal disease, and she was requiring hemodialysis for the past year. She was on a transplant list for a new kidney. Her medical history included steroids, prednisolone, cyclophosphamide, hydroxychloroquine, azathioprine, and MMF. And the MMF was prescribed because she was increasing her kidney failure, and it was assumed to be attributed to lupus. In the months leading up for the admission that we are currently discussing, the patient was experiencing severe and recurrent diarrheal episodes with 7 bowel movements a day, and they did not have any blood or mucus. And she also was presenting fever and painful flanking regions. She did a CT scan of her abdomen that revealed intestinal visceromegalia and bilateral hydronephrosis. The urine cultures had an E. coli that was sensitive to ciprofloxacin, and she did 1 week course of ciprofloxacin. But despite the antibiotic treatment, she continued to have fever, pain, and abdominal distension without an obvious source of sepsis. So, Thomas, this long-standing SLE history and the end-stage renal disease, do you think that might have contributed to this clinical presentation? And how do you feel about the persistent fever despite having treated the positive E. coli in her urine? What do you think about, what were your interpretation of this?
So I think the complexity of this case is really very substantial. We have a long-standing lupus with severe renal impairment, which per se in this combination gives a lot of immunosuppression. In addition, we have MMF on board. And I can already smell you're thinking about differential diagnosis. Maybe that's a kind of subclinical, not good recognized preseptic septic condition. Okay. That we took into account, and therefore we also decided to go with some antibiotic treatment. I think that was, but basically what speaks in favor of a kind of continuous replication of the bug of E. coli is that we had this continuous detection of E. coli in the urine. Ciprofloxacin at that time, although it was shown by the antibiogram to be not resistant but sensitive or sensible, we at least took 1 course of 10 days, but that might have not been enough. We should have escalated the antibiotic treatment and maybe avoid what then happened afterwards.
David, what do you think are the main differentials here?
Well, I think Thomas has highlighted the key issues, that this is a patient who's clearly significantly immunosuppressed, and that means, unfortunately, that infection is always the biggest concern. And in this sort of situation where you're not quite certain what the diagnosis is, my biggest concern, I was going to ask Thomas, where did this patient come from? Where was this patient? Was she originally from Germany, or where was she born?
So we have about 95% Caucasian patients. It's a different population.
Certainly in London, if I had seen a patient like this, especially if she had a background coming from South Asia, India, Pakistan, I would think of TB. I would think that somewhere underneath all this, a little bit of tuberculosis is lurking. And I say that from very painful experiences of having gone through not entirely dissimilar sort of problems, where finally, eventually, we find the mycobacterium. So that for me would have been a concern had this patient have been from that background. Without that background, it's less perhaps of a problem. But clearly, this is a persistent infection which has not responded, and as Thomas said, maybe it just wasn't treated long enough or hard enough or whatever. Hard to say. You worry also whether there is some kind of structural issue here within the bowel or some within the abdomen that can take many forms. So there is something beyond just the immunosuppression which is causing this, I suspect, but very hard to know what.
And maybe if I can add, the other differential aspect is that due to the situation of hemodialysis, we have some hemodynamic issues with overhydration and it looks like that there is a potential that we have a situation of spontaneous peritonitis, but we had at that time no ascites, and there was no possibility to get something by puncture to evaluate, for example, ascites.
I would also add MMF-related diarrhea, but it due to MMF toxicity, but it would not have intestinal visceral megalia, so it's kind of tricky.
Yeah, but David's point is great. I think I was just thinking we are doing in every arthritis patient, SPA, AxSpA, RA, TB testing, because we think about, but we do this not very strictly in every and each of our lupus patients. So maybe in your situation with your more global patient population, you do this, but we don't do this outside of arthritis, I have to say.
Yeah, it's interesting. Yeah.
We also do it because we had several years ago, we were on the high of the moderate epidemic threshold of tuberculosis. So we also do it in almost every patient that is going to be immunosuppressed.
Cool.
So going on with the case, 5 days later, the patient experienced a lupus flare with pleuritis, polyarthritis, low platelet count of 52,000, and she had reduced C3 and C4 complement levels, along with increased titer of dsDNA. Her overall SLEDAI was more than 10, at least 10, 12. So she was started on oral steroids, beginning with the 40 milligrams of prednisolone daily, and it was tapered till 15 milligrams daily over 3 weeks. The gastrointestinal symptoms improved within the 3-4 days of treatment with steroids. And she had a follow-up CT scan, and the LDH was reduced after the steroids. So now with the steroids response, Thomas, how do you interpret the case with this information?
I think we, at that time, and still I think, at least in part, I share this still, we considered this as part of lupus activity, as a kind of intestinal pseudo-obstruction, which can occur in some of the lupus cases as part of an increase of lupus activity, which is a very infrequent situation. Maybe we can discuss later about this, but it's a little bit more frequent according to the literature in India. But I cannot completely neglect the possibility that, for example, any tuberculosis or whatever could have been the cause, because I also learned when I was working in the ICU, sometimes you can treat for a long time quite semi-successful or with some success tuberculosis with corticosteroids. So therefore, I cannot take away this differential diagnosis, but it's important to take into account that we see a kind of pseudo-obstruction that not only can affect the gut, but it can also affect other smooth muscle organs, like, for example, can come with bladder dysfunction. And so we took this as lupus activity since the patient responded.
Okay. And after being discharged, the patient's gastrointestinal symptoms returned later the same year. And they were unrelated with the other markers of lupus activity. And she was readmitted and once again was treated with steroids and improved. So, Thomas, considering this entity that can be or not related to lupus activity and it responds to steroids, how do you interpret this physiopathological? It's almost guessing, but what do you think about this, the mechanism why it happens?
I can only share with you some of the ideas that are in the literature. The concept is that we have some smooth muscle dysmotility that can in particular affect the large bowel or gastrointestinal tract, leading to the pseudo-obstruction, the kind of inhibition of the smooth muscle activity, it's considered to be either a result from vasculitis or other immune-mediated mechanisms affecting or leading to myopathy. One can consider that some of the autoantibodies that we have so far not detected can lead to this. It's not in lupus, but in Sjogren's, for example. Tom Gordon in Australia described years ago a particular antibody against the Cholin, not the Cholin receptor that is relevant in myasthenia gravis, but in a different one that is sitting only in the bladder. And Sjogren's patients have these autoantibodies leading to bladder dysfunction. And it's a long loop, but one can think about the possibility that we have some immune abnormalities, potential autoantibodies interfering with the smooth muscle activity that come in this IPO situation and can be treated with immunosuppressants. Whether this is true or not, up to new generations.
David, what is your experience with this rare entity, pseudo-obstruction? And what do you think would be the differentials beside what you said about TP?
So my experience, it would not surprise you, is very, very limited. I think in 40 years now, I've probably seen 2 cases where I was convinced it was the case. So very, very, very rare. I should just say en passant that, of course, if you were doing a SLEDAI score of this patient, the score would be 0 because unfortunately it doesn't capture gastrointestinal disease. One point I'm going to ask Thomas about this. My general teaching over the years has been to say that GI lupus, gastrointestinal lupus, is very rarely occurs on its own. I've often, where I've seen it, it's usually been accompanied by other aspects of lupus. And yet the second time the patient came back in again, it seemed, as I got the history wrong, that you were saying to us, Raquel, and perhaps Thomas can quote, that in fact the GI involvement, the pseudo-obstruction, whatever, was an isolated clinical activity. Did I get that bit right? Was that the case?
Exactly, without any extra gastrointestinal manifestations. I don't know.
Even rarer. What a case. Yes, what a case. Gosh.
But so maybe in addition, at that time, I checked this again this morning, calprotectin was normal, so not excluding other issues. And in the literature, hypocomplementemia and elevated C-reactive protein, those are the 2 biomarkers that usually come along with IPO. And in India, the initial presentation in one publication reported 56% of patients starting with IPO before they go on into lupus, which is, I think, way beyond what we see in our territories.
Likewise.
Just finishing this discussion, this case presents more than gastrointestinal rare involvement. It represents how we can deal with the rarer manifestations in lupus. So there are no guidelines, there are no recommendations. And the thing here is, when you study and you are always uncomfortable when you don't know exactly what's going on, and presumably it's attributed to lupus, what do you do? Where do you trust to go for information to treat these really rare SLE manifestation? Thomas, can we start with his?
I would go in the Lancet Rheumatology, the Eminence paper by Professor Arnaud that he collected, and I looked this up this morning, and for the IPO case, I did not find any point what to do there. Only the rare gastrointestinal manifestations is maybe, it's only 1 paragraph in the whole review article, but he aggregated the knowledge of about, I think, 100 to 200 lupologists. That's for me one where I would look it up. And asking David.
Okay, David, go on. Where would you go?
Thomas has taken the words out of my mouth. I was going to say to you, Raquel, there's good news and there's bad news. The good news is that Laurent Arnaud has done, in essence, what you are asking. He's tried to get the combined evidence view from 50, 60, whatever the number was, people and has tried to identify what you might call the slightly more common, rarer events. But unfortunately, pseudo-obstruction is not one of them.
So it's really difficult. It's really difficult. So I'm talking to two of the most preeminent lupologists in the world, members of several steering committee, and you struggle trying to figure out how to treat this. So it's really difficult and challenging. And probably what I would say is that getting in contact with other colleagues that have a little bit more experience and trying to figure out in a multidisciplinary and several centers perspective, what would be the most acceptable or wisest approach. And honestly, for me, these kind of cases, they are humbling because we don't know everything. And it's really difficult to go there and see what are the molecules that are there, what are the cells that are doing this. So how can we treat with more precision for these patients? We are still very far off being able to do it in so many patients. So do you have any more comments on this? David, Thomas?
I absolutely agree with you. I think the one thing about lupus is that, as you say, it teaches you to be humble, because there are cases like these two that we've discussed, which cause a great deal of heart searching and intellect searching. And at the end of the day, you're still not sure if you got it right, if you did it right, or if you do the same things again. These are very challenging cases, and they come along in a way intellectually. It's nice, but it's nice to have a challenge. But they can be very, very difficult. And these two cases, I think, certainly exemplified that.
Thomas, any final comment?
Cannot agree more. We talked about the brain, we talked about the gut, we talked about vessels, etc. The kidney. What else can you have as a doctor when you're taking care about lupus? The other interesting moment is that we could discuss patients that we have seen and treated in the past and how we would do it today. And I think, although sometimes it's only gradually, but we see already and we can smell the breakthrough, how we developed. And I think the outcome of the patients has gotten better.
Thank you so much, David and Thomas. Thank you for being here with us today and sharing your insights in these two pretty challenging cases from your clinics. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus as far as you can. And do send us feedback on cases that you would like us to discuss in the future. Thank you so much for listening. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.